Hello my friend, I'm Dr. Elisa Choukroun, and today with my father Joseph we'll talk about the oxidative stress, an unknown mechanism that destroys the bone around our implant. You know, in life we often learn more from our failures than our success. And failures are not so rare in oral surgery. Sometimes we face failures in wound healing, bone resorption, and implant failure or even peri-implantitis. We know that the bone around implant, either native or grafted, is not always stable. And sometimes we see these complications enter our dental offices. Even if you use BMP2 in a graft, you cannot maintain the bone every time. So we ask ourselves, why does my implants does not integrate? Why are my sutures giving out? Why did my graft did not succeed? Why it resolves? And why sometimes with the same doctors, with two surgeries, the same materials, the same implant, the same protocols, we don't have the same follow-up, with or without PRF? Let's analyze the literature. From Albertson, we know that bone loss is not an infection. There is no evidence. We say it's combined factors. Do we know which one? No. From also this review from Amerlet and Tarnow, they say that tissue deficiency may result from a multitude of factors. But we still don't have any answer. We have to go and look for the answer in the basic science: anatomy, physiology, and histopathology. Anatomy. We know that we have a cortical bone around the trabecular bone, and that the vascularization is done through the Volkmann channels. Who supplies the periosteum? The soft tissue. And after the periosteum will supply the cortical bone and also the bone marrow. But the soft tissue, they play a key role in the vascularization of the underlying bone. Speaking of blood supply, how does a tissue become ischemic? From this huge article of Mamoto, we know that angiogenesis and blood supplies depend on the extracellular matrix elasticity. In simple words, if we apply pressure or tension on a tissue, it will lose its vascularity. And this is how a tissue becomes ischemic. Let's take an easy example of the effects of the pressure. Bed ulcers. If you apply constant pressure on a tissue for hours and hours, you will induce ischemia and necrosis. And this is why when we sleep at night, we have to change the position several times, because the tissue does not stand to have pressure applying on the same spot for several hours. To sum up, if we apply tension on the soft tissue or pressure on the bone, we will induce hypoxia and stress. And you know, in medicine, when we talk about stress, it's not psychological stress, it's oxidative stress, meaning an accumulation of oxidant into the tissue. What is oxidation? It's the combination of a substance with oxygen, leading to an oxide. During this reaction, an atom or an ion loses one or several electrons. and this oxidation induces corrosion. For example, rust. In contact with the oxygen, iron produces rust. But oxidation is natural, it's physiological. As aerobe species, we breathe and produce oxidant. We also name them free radicals. For example, the oxygen will lose an electron and become anion superoxide, a highly unstable anion and highly toxic. In response, our body produces antioxidant. And in physiology, everything is balanced. But sometimes our body produces too much oxidant or not enough antioxidant. In which situation are we producing too much oxidant? For example, hypoxia, inflammation, diabetes, obesity, cancer, or even intense anxiety. There are also situations where our body doesn't produce enough antioxidant. Diabetes again, but also smoking and hypertension. And this negative balance will create oxidative stress, leading to damages on the DNA and cell membranes. When we are under oxidative stress, the whole cell physiology is compromised. The body cannot heal naturally and properly. But also the immunity is compromised, and we face more risk of infection. And this is why we have higher rates of failure and complication. And speaking about complication, we know some patients with increased risk of failures. Yes, the diabetics, the smokers, or patients with kidney insufficiency. Why? These patients are under chronic oxidative stress, and this is why they have more complications and failures. The diabetics, for example, we know that they have difficulties in healing. Actually, hyperglycemia induces oxidative stress. But from more recently, we know that diabetes is a chronic inflammatory disease. And this explains why sometimes we do have complications in diabetics even when the diet is balanced. Diabetics, they have a bad healing because they have too many oxidants in the tissue. The smokers also. From a surgeon point of view, the problem is not the tobacco. It's not a vascular disease. It's actually the smoke, when in contact with tissue, will break down the antioxidant. And which tissue? The smokes enter the oral cavity, bone and gum, the skin and the lungs. And those tissues will have an excess of oxidant and thus a compromised healing. And you can understand now why sometimes after several years of smoking, the lung will develop cancer because of this oxidation. About the physiology, we know that the bone constantly remodels. This is the bone physiology. The bone is formed and resolved according to the mechanical strain. If the strain is normal, the bone volume maintains itself. If we have an intense strain, we can increase a bit the bone volume. This is the Wolff's law. But there are situations when in low strain, for example after extraction, or in higher strain, we have oxidation on the bone. And this is why the bone resorbs, because of this either too low or too high strain. When we face oxidative stress, we face failures in bone remodeling, because oxidants have a devastating effect on the bone. First, they inhibit the osteoblastic function. And having an increased amount of oxidant into the osteoblast is actually the critical element in the physiopathology of the bone resorption. And oxidant will also induce osteoclastogenesis. Now you understand that when in oxidative stress, you inhibit the osteoblastic function and you increase the osteoclastogenesis. And this is why the bone resorbs. To sum up, if we apply pressure on the bone or tension on the soft tissue, we create oxidative stress. And this stress will resorb the bone. And we can also have a poor wound healing. The bone have no intention of resorbing. Bone resorption is not normal. The bone resorbs because it's under oxidative stress. What are the consequences of the oxidative stress for us surgeons? What should we hope for a patient? Before, during, or even after the surgery, we have to help our patient to decrease the production of oxidant, but also increase the production of antioxidant. And when I say antioxidant, I'll talk about the inner antioxidant, not the one you can take from supplementation. They are always better, and we have to favor the self-production of antioxidant from our patient. Let's talk biology. Before an implant or a graft, at the examination, we often ask the patient, do you have diabetes? Do you smoke? Do you have any allergy? But actually, we should ask the patient, what is your level of oxidative stress? We have to assess exactly the quality of our patient bone metabolism. And we have two blood markers to assess this, the cholesterol and the vitamin D. And actually, this is the first article published in the dental field on those two blood markers, neglected the cholesterol and the vitamin D. It was back in 2013. What is the cholesterol? We have two types of lipoproteins, the HDL and the LDL. The HDL is named good. Why? We didn't randomly stamp them. HDL is a good cholesterol because it's antioxidant. And the L is bad. Why? Because it's oxidant. And the bad cholesterol, the LDL cholesterol, will deteriorate the bone health through the oxidation of the osteoblast. This oxidation will slow the bone metabolism, and when the bone metabolism is slowed, it is replaced by fat. And this is why sometimes the bone can have this yellowish color. And this guy, Brandmark, more than 30 years ago, he was saying to his students, when I see a yellow ball, I cancel the transplant. Why? Because he noted at that time that a yellow bone leads to more complication. Now we have the physiological and the biological explanation of this. This is why we recommend to dose the LDL cholesterol in pre-op, and it has to be under 1.40 grams per liter. Now, vitamin D. Vitamin D is actually an hormone and a major factor in bone homeostasis and in antioxidant production. We have vitamin D from direct sunlight or the diet, and it goes into a blood. Now there is two pathways. The first one through the liver and then the kidney, where it acts as an active hormone. And this is the endocrine activity of the vitamin D. It helps the absorption of the calcium. The second pathway is this one. Vitamin D is also found in all tissue. And with these active forms, when binding with its own receptors, the vitamin D receptors will act as a neuromediator to help the cells communication. And this is the autocrine and paracrine activity. Vitamin D here regulates the cell growth and produces antioxidant. And this is why vitamin D have so many effects on bone metabolism, wound healing, inflammation, and immunity. What are the serum levels of vitamin D? Usually we say that the good normal level is between 30 to 100 nanogram per milliliter. Between 10 to 30 we talk about insufficiency, but below 10 the patient is in deficiency. In this study, they analyzed a healthy population from 18 to 65 years old, and actually more than 90% of them were deficient in vitamin D. 3/4 were under 20 and almost 30% were in vitamin D deficiency. And this is why we have to test the vitamin D in pre-op before the surgery. But actually, why is this deficiency so common? We can easily explain it. Our ancestors, at the beginning of the humanity, they were taking direct sunlight on the skin because they were living naked. Nowadays, we have long clothes, we have caps, beard, we have glasses, and the skin doesn't get proper UV exposition. And you have to know that no one is safe. Even if one day an important person comes into your office and you have to do surgery, you cannot assume that they have a good biology. See, even if the President of the United States enters your office for a dental procedure, you have to check because he can be deficient in vitamin D and have hypercholesterolemia. We do have some types of patients that are systematically deficient. The elderly, patient with darker skin, obese patient with depression, but also smokers and diabetics. Let's talk about smokers. Remember, I told you that the smoke destroys the antioxidant, but the smokes also inhibits the synthesis of vitamin D. These patients, they have a double penalty. And we have to systematically test them and monitor them before surgery. And take care, my friends. We also have to change our question during examination, because we often ask the patient, do you smoke? But we have to take care about passive smokers. We have to ask the patient, do you live with smokers? Do you work with smokers? Because a passive smoker in our protocol is considered as a smoker, active smoker, because of the exposition to the smoke. The diabetic also, we saw that they are under chronic oxidative stress, but they also have fat excess, and the vitamin E gets trapped into this fat. And diabetics patients, they need vitamin D to function properly. Once again, we have to systematically test them and monitor them in vitamin D before surgery. And when we have those type of failures, it is no surprise to find hypercholesterolemia and vitamin D deficiency, because the body doesn't function normally. Vitamin D and cholesterol are major risk factors for osseointegration. What are the recent data on vitamin D? You know that vitamin D increases the production of antioxidant. But vitamin D decreases after surgery. It is consumed by the body during the surgery. It means that the supplementation is inappropriate. The official recommendations are from 400 to 600 units per day. Yes, these doses can prevent most surgical abnormalities, but they are insufficient to activate the paracrine and autocrine pathway of the vitamin D. if we want to properly activate them and stimulate the paracrine and autocrine pathway, we have to give higher dose to the patient, 10 to 20 times more than the official recommendation. We can take vitamin D up to 10,000 units a day and have serum level up to 100 nanograms per milliliter. Yes, it is normal in human physiology. With this dose, we don't have risk of overdose and toxicity. To give you an example, when you spend the full day under the sunlight, your body produces up to 20,000 units per day, meaning giving your patient 10,000 units is at no risk at all. There is an interesting studies on vitamin D toxicity. This article, they analyze studies reporting toxicity on several values. And what we see that below 30,000 units a day and below a serum level of 200 nanograms per milliliter, there is no toxicity. And with our protocols, we are in a complete, secure and safe zone. So now you understood the correct blood level for surgery. It's not 30 nanograms per milliliter. This is insufficient. We have to increase the dose to reach a serum level of 50 to 70 nanograms per milliliter. And now recently, the American Endocrine Society agrees with us on the serum level range. So our protocol, we test and we supplement all patients. Remember, 30 nanograms is not enough. For diabetics, we give them vitamin D, but also vitamin C, because they are deficient in vitamin C, a powerful antioxidant. We have to start as soon as possible and maintain this supplementation for at least 3 months, the healing period. The dose should be from 5,000 to 10,000 units a day. And after the 3 months healing period, we have to still give our patient vitamin D. If a patient is deficient one day, he will be deficient after 1 month, 1 year, or 10 years. So we have to give for a normal patient 2,000 units a day, and for risk patients, diabetics, smokers, or patients with chronic oxidative stress, 5,000 units a day. The supplementation principles are really easy. If your patient have high cholesterol, you send them to their medical doctor. But as vitamin D is actually a dietary supplement, we as surgeons can handle the supplementation. And it's really easy to find. The patient can provide themselves in vitamin D in pharmacy, herboristery, or internet. You can find high dosage of vitamin D even on Amazon. And my friend, in this particular time and pandemic situation, let's talk a bit also about the COVID-19. Which patients are making the most complication? The elderly, the obese patient, the diabetics, smokers, patients with hypertension, autoimmune disease, cancer, and skin color. In the USA, more than the half of patients with complications are African American. And all these patients, they have one thing in common: oxidative stress and deficiency in vitamin D, meaning they have a deficient immunity and cannot fight against COVID-19 and have more complications. If we want to prevent this complication, not only for our patient, but for everyone, we have to supplement every person in vitamin D. 10,000 units per day for adults and 2,000 for the kids. To summarize what we said on biology. First, vitamin D. Now you know that vitamin D is a hormone and the cell mediator and act as an antioxidant. In case of insufficiency, the patient will have bone oxidative stress, a deficient immunity, and more inflammation. And the cholesterol. We know now that the LDL cholesterol, the bad cholesterol, is oxidant. In case of excess, the patient will have a bone oxidative stress and a fatty yellow bone. Now, let's finish with penicillin allergy. There are a lot of studies on patients with reported penicillin allergy. They have 50% increased odds of having infection on surgical site. In implantology, Salomon talk about 4 times more failures. French talk about 3.1 more failures. But be careful, my friends, in case of immediate implant procedure, this rate can go up to 10 times. What is the mechanism? We know from the International Consensus on Drug Allergy that the role of T lymphocytes is sure. If the patient have a deficient immunity, he will have more risk to develop infection. But also the atopy, the allergy, is promoted by a deficiency in vitamin D. And finally, also the use of other antibiotics like clindamycin, vancomycin, and gentamicin may have a lower efficiency on infection. These patients, they have a deficient immunity and they have a deficiency in vitamin D. What should we do? Supplement them in vitamin D to restore a better immunological behavior. And we have to give them high dose of vitamin D, 10,000 units per day. They are at-risk patients, and we should start at least 1 week before the surgery. And speaking of antibiotherapy, you know that antibiotherapy is mandatory in oral surgery. Why? Because all of our surgery are contaminated. The patient breathes and the mouth cannot be a sterile environment. Sometimes in small surgery we don't give patient antibiotics. But see, when we don't give them antibiotics, the failure rate goes up to 4 to 5 times. So what should we do? How to manage the antibiotic for small surgery? The best is to give them 1 single dose of amoxicillin, 3 grams, 1 hour before the surgery. My friend, thank you for listening. Today, my take-home message to you will be, please manage the biology in order to succeed in surgery. Thank you, and now I'll let Joseph speak on this lecture. Thank you.
Hello, my friends. I'm Joseph. So let's talk about the soft tissue oxidative stress. It occurs during soft tissue ischemia. We will find the same etiology: excess of pressure, excess of tension. When do we meet pressure? This compression can be done by an abatement or by a carver screw. When we have, for example, a large screw, you see that we can reduce the space of the soft tissue, we reduce the bilateral width, and this is how we decrease the blood supply to the underlying bone. A large screw will induce bone ischemia. This is an example of a soft tissue stress. You see that the screw is large and then it reduces the space of the soft tissue. And this is why the bone is resorbing, because the blood supply to the bone is much less. So if we reduce the abatement size, then we will say the soft tissue can breathe, can get more blood supply, and then the bone can be rebuilt. The situation of excessive tension, we know them. we know that the tension is created by the flap closure, and then we induce oxidation. When we close after extraction, when we close after augmentation, or when we have a short vestibule. For sure, the flap management is fundamental, and we have two deleterious effects from the tension. The first is that we induce ischemia and we delay the soft tissue healing. But in the same time, we reduce the blood supply to the underlying bone. The tension induces also pressure on this bone, and this is how tension will induce bone oxidative stress. First is the analysis of the flap elevation. We know that when we raise a flap, we lose the bone. And then the question is it better to do a surgery flapless or not? We can ask the literature. Some authors, they will say flapless will be followed by less per-implant bone loss. Others will say there is no statically differences. And other authors, they will advise you to elevate the flap in order to improve angiogenesis and bone growth. The conclusion of this review is that this is not the issue. It's not the issue of making a flap or not. We can analyze also the soft tissue thickness. Some authors, they will tell you that take care about the soft tissue thickness, because if you don't have, you will lose the bone. But it's a personal opinion from my side, because other authors, they will say and they will show that thickness has no influence. So again, no one agrees, and we will not follow this concept. Finally, what is the issue when we raise a flap? There is only one issue. The flap becomes mobile. And when the flap is mobile, the blood supply to the bone is interrupted. Then the question is when this blood supply will come back, when the bone will recover the blood supply. Only when the periosteum will be reattached. So when and how much time do we need to achieve a reattachment? We have the answer. From Sclafani, we can see that after only 4 weeks, we can achieve 70% of reattachment. And it takes more than 6 weeks to achieve a significant reattachment. And in all that time, the people are living, smiling, eating, scoffing. There is a permanent mobility and tension after many days and many weeks after the surgery. So we can explain now why we are meeting some periimplantitis, because there is a chronic tension into the vestibule. When you have a chronic tension, you know that the bone is falling under oxidative stress. Look at this case. We are starting to lose the margin bone. Why? Because there is no vestibule. And when you have no vestibule, it's sure that you will lose the bone. The rule now is that we need to achieve a tension-free flap closure. But how to assess this tension? There is no device to evaluate the tension. And we forget very often that we are doing surgery with local anesthesia. And what is the function of the local anesthesia is to make the muscles flat. And then the tension is masked during the surgery. And if we want to assess the tension, we just need to pull on the lip. And this is what we will see. We will see the mobility and we will see the tension. When we pull on the lips, we will see the tension. And then if we want to understand and to prevent the soft tissue oxidative stress, we need to remove the tension and we need to stop the mobility by fixing the flap. The flap release, we know how to do it. Usually we do a periosteal incision, we can use the soft brushing, but the concept is that we must over-release the flap. Usually the people, they do the release just to close the flap. This is not enough, because when you close the flap, there is still a lot of tension. Then this is why we advise to make an over-release. We consider that we must release at least for half or 1 centimeter more than necessary to close the flap. This is the first. The second is that we must immobilize the flap in order to get back, to see coming back the blood vessels into the Volkmann channels. And if we want to immobilize this flap, we need to use an appropriate suture technique. This is why I propose this technique, the apical mattress. The apical mattress is an horizontal mattress, but very deep. This is why it's apical. At least 1.5 centimeter from the margins. And then when we close, we are sure that the full flap in the buccal zone will be fully stabilized. This is the apical mattress. We go deep into the vestibule. We do the mattress, classic, horizontal, but deep into the vestibule. And this is how we should stabilize the buccal flap. With classic sutures, the mobility is obvious because the buccal flap is not fixed. But if we change this suture to an apical mattress, we will see that we stop the mobility and we stop the tension in the buccal flap. The apical mattress will give you a full stability, and then the tension is moved above the suture. And when you have no tension, the normal behavior of the gum is to move down. And this is what will happen. When you have no tension, you will see a very nice growth of the soft tissue, and it will be stable. When we do an apical mattress, even if we pull the lips, we see that there is no mobility, even if there is not yet a primary closure. When we pull the lips, this is what happens. But if we don't fix the flap, the tension will remain. And then we will meet a secondary wound opening because we forgot to manage the tension in the buccal flap. The question is now when to remove and which kind of suture to use. Just a reminder, we need at least 4 weeks to achieve enough reattachment. Then we will say the threads must stay for at least 4 weeks. This is not common. Usually surgeons, they remove the sutures after 1 week, 2 weeks, 10 days. No, we must stay 4 weeks if we want to help the periosteum to reattach completely. Too often, the threads are removed too early, and we meet the wound openings mostly after the threads removal. If we want to stay 4 weeks, then it's impossible to use some qualities like silk, like Vicryl. We need to avoid definitely to use a braided suture. The only one solution is to use a monofil. A monofilament will help us to reduce the inflammation and the plaque on the braided sutures. We can use a non-absorbable monofil, nylon or PTFE, but if we want to leave this suture for 4 weeks, obviously you will meet the threads inside the gum, embedded into the gum, and therefore it will be difficult to remove them. So the only one solution is to use a monofil absorbable. I proposed this kind of suture almost 10 years ago because we can use a specific monofil which has an ideal absorption time, 4 weeks. And then we can see the impact on soft tissue thickness. When we use a monofil and we leave it for 4 weeks, but we don't remove it because it's resorbable after 4 weeks, then we can achieve a very nice thickness of soft tissue. This is what we do daily. We fix the flap and we leave the suture for at least 1 month. Even in soft tissue management, when we do a tunneling technique, we can use any kind of material, PRF or connective tissue. But what is the most important time? What is the most important protocol? Is to fix the flap for a long time in order to achieve a good attachment of the periosteum. What about the bone oxidation? Again, it's initiated by unreasonable pressure. How the bone comes under pressure? We know who is making pressure. The soft tissue, because the after extraction or after bone augmentation, when the tissue is stretched, it presses the underlying bone. But we have also another enemy, which is the implant. When we place the implant with an inappropriate torque, we will create high pressure. How the soft tissue applies pressure? We have so many publications about the resorption of the buccal bone after extraction and implant placement. The theory was because the socket is empty. No, this is not the origin. The origin is because we try to close the gum after extraction, and then the gum press the bone. I want to show you a simple case. Implant after extraction, it doesn't matter what we put into the socket. The most important is how to stabilize and to fix the buccal flap. And we will see, in this case, the gum bead made by the coronal advancement of the flap by the apical mattress. And if you save the bone from the pressure, what will happen? At 3 months, you have no buccal bone loss. You can see in the CT that we made a 3 millimeters vertical bone augmentation without any bone graft. Why? Because when you do the suture, you advance coronally the periosteum, and then the person has an upper level. And then the bone can grow vertically because the periosteum is upper. The gum press permanently the bone. And then in this case, we can see how when we don't protect the bone from the pressure, we will lose the bone, and in this case, the bone graft. This case was an extraction, and after 2 weeks, the patient met infection. We removed the non-resorbable membrane, and we waited a few months in order to meet a bone healing. This case was not done by us, but when we wanted to place an implant, it was impossible because the healing was not good. So what was the treatment? To fill the gap, again, whatever you use to fill the gap. But in this case, you can see that we have 2 flaps, one lingual and one buccal. If we follow the literature, we will say definitely we will lose the bone because we did a flap. But we don't agree with this theory. For us, the only one action is to fix the flap and to remove the tension. This is what we did. Apical mattress, fixing the flap, and then we can see what happens after 3 months. After 2 months, we increase the ridge thickness, not with bone augmentation, just by a suture technique. When you create a space and inside the periosteum, this space will be filled by the bone. And how to make this space? By the apical mattress suture. I talk about protection. We know several techniques, very nice techniques, working well. All the techniques who are working well are protective. Curie technique, it's autogenous bone, but it's a protective technique against the pressure from the gum. When you use a mesh, a titanium mesh, the objective is to protect the bone graft against the pressure from the soft tissue. When we use a screw, when we use a PTFE, reinforced PTFE membrane, the concept is the same, and this is why all these techniques are working well. You can select what you want, but you must follow the concept to protect the bone from the compression of the soft tissue. Using screws is the most simple technique because while you stop the pressure, you will meet the bone. And then at the head of the screw, even in vertical augmentation, you will meet the bone at the head of the screw because the screw will stop the pressure of the soft tissue. In this case, it's the same concept. It's a protective bone regeneration. When we have a huge augmentation, we must organize a space without pressure. We can use a simple mesh. This is the fast system. And this simple mesh will allow us to rebuild the full bone volume because the bone is not under pressure. And then at the reopening, the full space is filled by bone. We don't need to wait too much. 4 months, it's enough. And then it's easy to remove the titanium mesh because it's a non-osteointegrable titanium. It's the grade 2 titanium. And then we can place several implants, almost 10. Vertical is the same concept. Just organize a space without pressure of the soft tissue. Sutures, apical, mandatory. Don't forget to make an apical mattress around the premolar because there's a huge tension in this area. Sometimes we need to cut the mucosa in order to release more the tension. You remember the over release. We release always more than necessary. And then you see the full space is filled by bone. This is a true vertical augmentation with a simple mesh. But you understand that we are following two concepts. Stop the pressure, over-release the flap. I want to show you two techniques. The two are working very well. On the left, you have the Curie. You go to the ramus, you harvest the bone, you prepare the bone, you put the bone plates, and you screw them. On the other side, you have exactly the same. A sinus with a vertical augmentation. But in this case, we use just a simple system to organize a space without pressure. What is the result? Exactly the same. But you understand that using just a spacer will be done with much less time. The same reason than with autogenous. And you don't need to be an expert to place a screw. The implant is also a good material to press the bone. You know the concept. The concept is that today we use implants and we are meeting more and more periimplantitis. The question is on all the lips. Why? Again, as told you Elisa, we must go back to the basic science, not to the literature. We don't have yet the explanation, but we have already the explanation in the basic science. And first, we must talk about the primary stability. Should be reconsidered? Definitely yes. Because in many cases, the primary stability will induce a lot of oxidation. If we go back to the physiology and the Wolff law, you know that remodeling depends on the mechanical activity. Okay. But what is this mechanical activity? Normal. Walking, running, chewing. But you can analyze that this activity is not a full constant activity. This activity is cyclic. We press and we relax. We press, we relax, like when you walk. But when we analyze the action of the implant is pressing permanently. And then we can ask a question, simple. Do the implant placement is unphysiologic? Maybe. We will see. First, how does the bone react to the implant pressure? Okay, we put the implant, we torque it in order to get a good stability, but what is the reaction of the bone? We have the answer. Since more than 300 years from the Hooke's law, a material reacts to pressure according to its density. What does it mean? If your material is soft, flexible, there is no stress, like when you press a sponge. If your material is dense, then you have a high stress and the material will break. Exactly like with the bone. We have different kinds of bone. We have the trabecular bone, we have the cortical bone. In trabecular, we know that this bone is flexible. Then, even if you put an implant with torque high, there is no stress because the material is flexible. But if you put an implant with torque and the cortical, this material is rigid, and then you have immediately a very intense stress. I would like to show you just a picture to understand that a pressure on a bone of 35 Newton, imagine a clamp on your head with 35 Newton. You will not support more than 5 seconds because it's very painful. And then now you can understand that it depends where we apply this pressure. When we put an implant, the issue is the cortical bone. At the implant neck, this bone is poorly vascularized. This bone cannot tolerate the pressure. And then it's obvious that the close contact between the cortical bone and the implant will be harmful to the bone. When you place an implant into a ridge, in the cortical zone there is a high stress. In the spongiosa, there is no stress. And this is why we meet the margin bone loss. The margin bone loss is only because we press the cortical bone. We have another example. When we place the implant to buckle, it's not the position of the implant which is dangerous. It's because the implant will be in contact with the cortical bone, and then it will induce resorption of the cortical bone. Sometimes you place an implant and the cortical is too thick. You will meet very fast a crack, because when you press the cortical bone, you put the cortical bone in oxidative stress, and there is no other issue than to resorb. Placing an implant and meeting bone loss means you put a too much high pressure. It's not the titanium, the quality of the titanium who induce stability or not. It's just how much pressure you put on the bone when you place your implant, but on the cortical bone. And when you start on the cortical bone, you don't know how it will be finished. You start with the resorption, and then we don't know what will happen in the future. You understand that we must protect, preserve the cortical bone by doing maybe an over-drilling into the cortical, 2 millimeter depth. For me, for us, today, a good implant placement is a placement with no stress on the cortical bone. We must meet a space between the implant and the cortical in order to be sure that this bone will never resorb. How to do it? By a drill, by a countersink, just 2 millimeter depth. And then you save definitely the life of the cortical bone. This is why we will, we will evaluate the reach before the implantation. Not to make a planification with a software. No, it's a medical and biological examination. How is the cortical thickness? How is the cancellous bone? And then you will adapt the placement according to the quality of the bone. If the bone is too dense, reduce the torque. If the bone is not dense, you can increase the torque. In this case, implant placement is safe because the implant is only in trabecular bone. Then you can place implant with high torque. You can do immediate loading, but don't forget to overdrill the crest. In this case, it's obvious that the implant will kill the cortical bone. It's impossible to place with high torque. It's impossible to make immediate loading. This is how we must plan the surgery. One case, it's enough to explain. This case has 10 years follow-up. There is absolutely zero bone loss. Why? Because the implant is in a full trabecular bone. Then you can save the bone over the implant. This is how we must place an implant, with no stress on the cortical. You can load it, you can do what you want. But if, by chance, you have the contact of the implant with the cortical bone, definitely you will lose it. You see, this is what happens when the bone is too much cortical. And when you place an implant and you want to make an immediate loading. What is the evolution of the bone graft? We do graft and we lose sometimes. And we don't know. Maybe we say because it's the material, because no. Again, the biology will help us to understand why we lose this kind of bone. We do graft and we lose the bone, even if it's autologous. We do graft with the current technique, and even if it's the best technique, we lose it. We lose the bone in depth and in thickness, both. You place implant after a sinus augmentation and you lose the bone. We place implant into a bone from Calvaria, and even if the bone is one of the best, we can lose the whole graft. We can use BMP. Bone doesn't care. The bone has only one behavior. And then we need to understand how, and we say how to manage. Just the last example. We did an apposition graft in the mandible, horizontal, and the lady disappeared for 2 years. She came back after 2 years and she said, I want implant. The crest was absolutely perfect, even after 2 years. Means, without implant, the bone can be stable. But when we placed the implant, we lost the bone, the buccal bone. So, The evidence now is that the grafted bone resorb after implant placement. Basic science will help us to understand exactly why. First, de novo bone is a trabecular bone. But the question is, how's mechanical characteristic of this kind of bone? We don't know too much. We have poor education on this bone quality. But we can make a very strict analysis. When we graft without biomaterials, like example, we put a plate in the sinus and we leave only the blood clot. After a few months, we do histology, and what do we see? We see that we have a 100% vital bone, perfect bone. When we do sinus with PRF, PRF is a blood concentrate, we will meet exactly the same quality. 100% vital bone, only trabecular. Okay. When we fill a socket with PRF, we meet again the same quality, 100% trabecular. Let's go to see what happens when we use only a blood clot. We will meet a trabecular bone, which has a good mechanical behavior. It's less sensitive to pressure. When we use a biomaterial, what is osseointegration? Means bone is growing on the surface of the biomaterial. This is the osseointegration. But when the bone is growing, it's totally interdependent with the biomaterial. It means that the new bone and the granules becomes one entity, one piece, like the titanium and the bone. Osseointegration means full contact. Let's go to analyze different kinds of graft: autogenous, allograft, xeno, synthetic. When we use xeno, we see that we have the same behavior. We have the granules, and the granules are totally covered by the new formed bone. Bovine or porcine, they have the same behavior. Bios, this is a histology from Dr. Urban, we have the same. The new bone is really in strict contact with the granule. Synthetic, we have exactly the same, because the bone is growing on the surface of the biomaterial. With human bone, autogenous, we have the same. With allograft, we have the same. Bone is growing on the granule. Dentin, again the same. Bone is growing on the surface of the biomaterial. Then we have the same pattern. The conclusion is that the de novo bone, when we use a substitute, is exactly the same, whatever the kind of bone substitute we use. But it's also trabecular. But there is a big difference between the two kinds of trabecular bone. When we fill only with blood or PRF, we have a full trabecular, but all the trabeculae are of pure bone. When we do a bone graft with a biomaterial, we have a trabecular, but these trabecular are mixed and stiffened by the granules. They are not the same trabecular bone. If we analyze through a mechanical aspect, sometimes you can take a sheet of soft material and you can fold it. Easy. But if you stick two plates, you will see that now, when you stick them, they become rigid. It's the same for the bone. When we have a full trabecular bone, it stays soft. But when we put granules inside, the new bone became compact without any plasticity. And this compact bone, we can say now that this dense bone will have a behavior as a cortical bone. Big difference. In one side we have trabecular bone, and in other side we have a trabecular bone which behaves like a cortical. Then we can understand that we must take care. What is the surgeon delight? The surgeon, they enjoy to drill into a dense bone graft. This is their pleasure. And when they meet a dense graft, they apply a high torque because they believe that it will be good. Definitely, it's a big mistake. You are not allowed to apply a high torque on a dense graft because it will be fatal for the graft. And you understand why the bone graft resorbs. The grafted bone, whatever the origin, is behaving as a cortical bone, and it will disappear when you abuse it. Look at this case. Interesting. 42 years follow-up. 42. This lady, she was 18 years old, and she got a cancer of the mandible. They did a fibula graft. And after 42 years, the bone is still there. It's autogenous, full. But it's stable. Why? It's stable because there is no trauma, because there is no implants. And you understand that implants are dangerous into a bone graft because we usually place the implant with a high torque. An example from my friend Joseph Kahn. He waited 1 year to re-enter. 1 year. And then after the augmentation with screw tenting, simple, the bone is so dense, but the future of this bone is critical because too much dense and it will behave as a cortical bone. This is why we decided, and we do today, an early re-entry. We don't like to meet a dense bone, too dense. We just need to meet a bone where we can put an implant with good stability. What we do, we put low torque because we know that this bone is very, very weak. We do over drilling crystal in order to protect the last 2 millimeters. And then we are sure that the bone will be stable over time. I cannot finish my lecture without talking about PRF. Of course, I must talk about PRF and oxidation. What is the function of PRF? PRF stimulates angiogenesis. PRF has a good anti-inflammatory effect. And recently, this year, we got an interesting information that PRF inhibits osteoclastogenesis. Then we can conclude that PRF is a very nice antioxidant. And this is why PRF is good for healing. First, because it reduces the oxidation of the site. Soft tissue or bone doesn't matter. When you put PRF, you reduce the oxidation of the site. But the period of activity is very short. It's the period of the life of the PRF. It means 1 to 2 weeks, no more. But it's enough to start a good wound healing. Since a few months, we launched the sticky bone and the new protocol with the SPRF. And this is a huge improvement. Why? Because the sticky bone is also an antioxidant. Because we bond those granules and we compact them. And after, all the gaps between the granules are filled with the fibrin. And this kind of sticky bone is reducing the oxidation into the bone graft because the granules are not mobile. And we know that the mobility is the main factor of the oxidation. The mobility induces oxidation. But we have also the space filled with fibrin. And we reduced the space between the granules. And this is why we say today that we will never use the old form of the bone graft. We will use only sticky bone because it works so nicely. Because it goes fast because of the low oxidation level into the bone graft. An example, we put the bone sticky, always sticky. But we see that even if we don't close the site, the gum will come to cover the site because there is no oxidation. Another case, we open only after 10 weeks. And look at the evolution of the bone. The bone is growing over the implants. Why? Because we used a good bone, we did a sticky bone, and we closed with the apical mattress in order to increase the bone height. It's possible. It's possible. Sure. Another case, just to show you how we go fast today. Extraction and implant, application of sticky bone with this new kind of bone graft from Purgo, the graft. No collagen membrane, we don't need. And then let's go to reopen only after 6 weeks. 1 month and a half. And what do we see again? The bone is covering already the implant. We stabilize the bone graft because we are very kind, we will say, with the bone. The sticky bone is really a revolution, my friends. And I advise you to move to this technology. No bone loss in the buccal zone. To finish this case, because it's a resume of what we said, Elisa and myself. This is a huge bone loss after implant with a critical vertical bone loss in the maxilla. Then we started to make our protocol with following all the concept. Vitamin D. Look, only 3 small meshes to build a space without pressure. This is the fast system I designed 10 years ago. Compacting the bone all the time. A lot of compaction, as much as we can. And what is the follow-up? We don't need to wait 9 months, only 4 months. And look at the new ridge. How is rich in bone, only after 4 months. No collagen membrane. And then we go to make a biopsy. Look how the bone is dense. But the interesting is the histology reports. From the maxilla, we did 1 biopsy. And the surprise was to meet, after 4 months, 50% of new bone. 50% of new bone. 4 months. No collagen membrane. The second sample was in the posterior maxilla, and the histology was 40% of new bone. But this is not the main interest. The main interest is that when we analyze the bone that we got from the biopsy, okay, we place the implants. First, this is the new ridge, but what do we see in the biopsies? We see that the connective tissue is very low. 10%, 10 to 20% of connective tissue. What does it mean? It means that if you do good surgery with much less oxidation, the competition, we know the competition between the connective tissue and the bone. We will win the competition, very simply, by using all the steps of this protocol. We name this protocol, the full protocol, the over concept. Following this concept, we can win the competition with the connective tissue without membrane, because it's another thinking about surgery. So, my friends, it's time to leave. Today, we will launch very soon the new revolution into the PRF. It's the pump pack. What is the pump pack? It's a small device, And this small device will allow you to get a very big clot simply without changing the tubes, without changing the centrifuge. Just by using this device, you will get much bigger clots all the time, every time. And this pump pack is given for free to all our customers. My friends, I thank you for your attention. Thank you and see you soon.